Hi, everyone. Welcome to the live Q&A session. We're still having migration of participants, but just um, in case you would like to ask any questions that you didn't get to ask during the session, please feel free to put them in the chat. We'll also try to expand a little bit upon some of the questions that we began to receive during the webcasts. So I'm Tanya Dorff, genitourinary oncology at City of Hope, and I'm joined by my very esteemed colleague and truly wonderful human being, David Quinn.
Wow. On a Sunday morning, I don't get better than that. Hi, I'm David Quinn. I'm a genitourinary medical oncologist at the University of Southern California. I'm happy to be joining you this morning with Dr. Dorff. All right, now we're going to start off with the question that came just after you finished. Piece one is confusing. What is the bottom impact in your practice?
Yeah, I figured there would be a lot of confusion, unless, of course, it was just me who was confused at the end of the presentation. I mean, I think there are some clear take-home messages, and then there's just a lot of unanswered questions. So bottom line for me is I used to have some hesitation about using docetaxel upfront intensification and then transitioning to an AR targeted agent because in Enzamet we didn't really see much benefit for that. But I think this study does give me a little more confidence that I'm benefiting patients and not just bankrupting them by using more than one upfront intensification strategy. Because I think we've all had those patients in our practice who are just really bulky disease, really aggressive, and we would like to do more than just 6 doses of docetaxel or just the AR targeted agent. So I think piece one gives us good level one evidence that we can add the abiraterone after either upfront docetaxel or the radiation to the prostate primary. Now, David, I think this is a chronically challenging issue. There's a question about managing toxicities like diarrhea when you have a VEGF IO combination. How do you know which agent is the culprit? What are your strategies there?
So we have most experience with pembro and axitinib in this combination because it was one of the first approved. And you can get diarrhea from pembrolizumab and also from axitinib, but just any checkpoint, any VEGF. The good news with axitinib is that if you stop it and the axitinib's the cause of the diarrhea, it'll usually be better in about 3 days because of the very short half-life of axitinib. Whereas if it's then continuing, you need to think about whether the patient's got immune related colitis and start considering steroids, which I tend to give early. So if the patient's not better on day 4 and they've been on the combination, I'll be looking to give them oral steroids. I'll also be looking at them to see whether I need to give them intravenous steroids if they're looking sick. So that's kind of the thing in a nutshell. But with the other agents, such as Cabo, soon Lanvatinib, they have longer half-lives, so it's a little more difficult. So you have to wait a bit longer and follow the patient a little more closely. So they get a phone call 3-4 days after I stop, and then we're talking again in a week to make our decision, and hopefully they don't deteriorate in the meantime. All right, now there's a question about PSMA scan and lutetium PSMA treatments. Where are they being given now? And are they only available in clinical study at the moment?
Yeah, so it's frustrating because we know this is an active agent, the lutetium-177 PSMA, and yet it is a little bit challenging to get your hands on it. FDA is reviewing and hopefully approval will come through, which will create broad availability. In the meantime, there are compassionate access protocols rolling out, and it's possible that there may be access at UCLA. I know UCSF has been studying lutetium-177 together with pembrolizumab, and so I've sent some patients up there to try to access it that way. In terms of PSMA PET scanning for the gallium-68, it was only approved at UCLA and UCSF, so those remain the major places to get those, although the VA does offer, little known fact, so if you have a veteran, you can try to get them over to the VA. When we get the DFC PYL, the F18 based PSMA tracer in our hands, so it's been FDA approved, but at least as of this past week, my radiology team couldn't yet order and obtain a dose. But as soon as that infrastructure is flushed out, we should be able to more broadly use, since it's an F18 PSMA tracer, it won't be as restrictive to centers that have the ability to produce it on hand.
Yeah,
All right, David.
there are multiple platforms that will become available in the next month or two. And if you've got a pretty much standard nuclear medicine operation, you'll be able to offer it. There'll be issues about whether insurance covers and what have you. Sorry.
Sure, reimbursement will be a question, but you'll be able to order it much like a flucyclovine PET, right? It should be similar. Yep. There's a question about avelumab maintenance. Is it now standard for PD-L1 positive bladder cancer patients?
So avelumab maintenance is standard for any patient that has on a platinum combination, including carboplatin combination, a stable disease response or better. So if they have a complete response, partial response, or a stable disease at the end of their platinum therapy, minimum 3 cycles, then avelumab is a standard. It is not restricted to PD-L1, although you would notice in the presentation that patients who were PD-L1 positive appear to do a little better. And in fact, the longest patient that I've had on avelumab now, quite a long time, is completely PD-L1 negative. And so they seem to have been maintained, and they had just stable disease. So it does not, the PD-L1 does not predict. And then of course you've got an issue as to what to do with the patients that progress on chemo, but that's another question. Okay.
And another question. Oh, go ahead.
You go ahead.
I think there are more questions for you. So I'll pose you another one. What is your treatment of choice for good risk metastatic RCC in the first line setting?
So I think this is philosophical. There's not an overall survival benefit in any of the combinations of IO or VEGF-IO in the good risk patients. And the problem is that the good risk patients take a long time to die, and therefore our event rate, which correlates with that in these studies, is a problem. But generally, the curves are not even going apart. So the standard answer is it may still be just a VEGF TKI, whatever you want to use first. But there are arguments that particular patients may benefit. So for example, if we look at a very high response rate in these patients, particularly complete response rate, which occur with a VEGF IO combination across the board, you may want to treat that patient because if they get a complete response or a response, they often go on for a very long time. Of course, you've then got the cost toxicity in a patient that is not having a response, just has stable disease, and how long you should continue that combination. So that now the good risk patients, metastatic, are the ones that I actually have to spend a lot of time on. And I think you kind of wonder what additional toxicity they're going to get from IO therapy. All right, so I need to try and scroll up on my window so I can see something. So just bear with me here. So let me ask a question of you about, which I asked in the chat. So you've got patients that have got metastatic hormone sensitive disease, and notwithstanding other factors, you want to try and give each of them an LH, RH agonist or antagonist, and then you want to add something, a pill or chemotherapy or maybe radiation to the prostate in selected low-risk patients. Are there patients you're not going to do that in? Are there patients you just want to treat with old-style, straight androgen deprivation therapy?
Yeah, I think the real world data suggests that uptake of upfront intensification for metastatic hormone sensitive prostate cancer is slow. And I think the session at the post plenary session after Enzamet kind of spoke to that too, that there are clearly a lot of oncologists who feel like some patients should just get castration or LHRH monotherapy. I really think most patients can tolerate a drug like abiraterone or enzalutamide or apalutamide. So I do think most patients should be a candidate. There might be financial constraints, but you do have docetaxel as an option potentially if it's a prescription issue. But in my own practice, I would say it's really just a handful of patients who are only getting LHRH monotherapy. These are gentlemen with significant cardiovascular comorbidities, limited life expectancy, or profound frailty or at risk of frailty, where you might want to watch and just see how they tolerate testosterone suppression first before going even stronger. But yeah, the vast majority in my practice are able to receive and do receive upfront intensification because we really see from all the studies how much that prolongs survival without a big cost to quality of life. You know, to your point that you were making in RCC as well, that it matters a lot for our patients, but the LHRH, at least in my experience, drives a lot of the toxicity.
Right. Yeah. Okay. And do you have a preference between using an LHRH agonist or antagonist? And are you using the new antagonist pill, Regularis?
Yeah, I mean, I've been a fan of antagonist for monotherapy in particular because it is more effective than agonist and has the better cardiovascular safety profile. I think once you start combining, it really may not matter as much. And certainly for the oral agent, relugolix, there's not a lot of combination data. So anyone who's going to have combination therapy, I'd feel more comfortable using an injection.
Right. Okay.
Now, you've gotten some interesting questions, some really challenging ones. Sarcomatoid RCC and adenobladder. Do you want to tackle one or both of those?
All right. So the sarcomatoid RCC is a patient who went on Nivo-Ipi and developed skin nodules on Ipi-Nivo. And the biopsy of the skin nodules showed, I think it's sarcoid, not sarcomatoid. So you can get emergent sarcoid on immunotherapy. The patients I see it in are typically African American and Afro-Caribbean. And so if I see a skin lesion in that population on immunotherapy, I do biopsy it. Now, then you have a question. Do you continue immunotherapy, in this case, continuing Nivo, presumably they got through their first bit of the IPI, and then they have progressive disease. So because if the sarcoid gets worse, you've got a problem. If the cancer gets worse, as oncologists, we know what to do with that. And so typically in this setting, I would use cabozantinib. And when I've put patients with sarcoid on VEGF TKIs, their activity in the sarcoid seems to become less. Whether that's really true or just me imagining it, but that's actually a reasonably good option for me.
Do you think sarcomatoid is particularly MET driven? Is that why you like the cabozantinib?
Look, I think it can be, but it tends just to be aggressive, and I think that cabozantinib is probably our best VEGF TKI as a single agent, based on the Cabo-Sun study, which was done in intermediate and poor risk patients in the first line, and then second line from Meteor. I think we have that data. So I think I kind of picked that for activity. Remember in Meteor, a Cabo produced a survival advantage for the first time. And so I think it does have significant activity.
And before we leave RCC, we did that study with Brian Reaney a while ago
Yeah.
of observation. Is that still an approach you take for a low volume asymptomatic patient?
Well, I can ask you the question because you did most of the work on that trial. But the answer is yes. Observing patients, particularly with pulmonary metastases that are slow growing, is fine. And on that study by Rini Dorff et al., they showed that you could watch patients for up to 3 years, and we have these patients. The other thing is that metastasis for a limited number, typically less than 4 metastases in the lung, improves survival. And so you can resect those patients and watch them. And so you don't need to treat everyone in that group, but most patients are going to end up needing therapy at some stage. All right, there's a question for you. If and when do you use PSMA scanning for high-risk localized patients to decide on treatment, surgery versus radiation, port fields, relative to detection of non-regional nodes, etc.?
Well, so of course, it's still hard to get a PSMA PET scan, but I do think high risk localized patients are probably the prostate cancer patients who can benefit the most from PSMA PET because we are probably missing occult metastases with conventional imaging. So, there is a lot of debate right now among experts because all of our treatment paradigms have been based on conventional imaging, but they've really shown again and again that if you draw your patient's radiation plan, for instance, and then do the PSMA PET, that about half the time some of the disease falls outside your plan. And it would seem, non-intuitive to ignore the information from a PSMA PET scan based on the amount of data suggesting it's accurate and it's sensitive and fairly specific. So there's not level 1 evidence for acting on PSMA PET yet. There are a lot of ongoing studies, but I think if your patient is lucky enough to be able to access it in a high risk localized patient, I do incorporate what I see on the PSMA PET in my treatment plan. If there's something outside of the region with radiation, then maybe we're going for intensification, like a stampede type approach with abiraterone in addition to the radiation, something like that. But that's definitely a tough question in an evolving field.
Yeah, I think also the radiation oncologist like something to shoot at rather than if they're making the decision about the nodes. And Axeman helps us there. May not be as good as PSMA based on the UCLA data.
All right, we have a question about neoadjuvant IO prior to cystectomy.
All right, so these are for patients that are cisplatin ineligible or declined cisplatin. There are 2 phase 2 studies, one run with Atezo, one with Pembro, showing P0 rates, complete response rates, that are interesting. And the FDA doesn't quite know what to do with that because benchmarking that for them is difficult. So for a patient who's truly not cisplatin eligible and you can't give split dose, or they just don't want to have it, there's a choice between going directly to surgery or a trial. At USC, we have a trial with Pembro and a novel agent for 3 or 4 cycles before surgery that we're looking at. But I would not give it outside of a clinical trial. Many patients can be talked into split dose cisplatin gemcitabine chemotherapy. And once again, in publications from Dr. Dorff, she's shown that's safe by and large and likely to be more effective consistently than IO therapy. Also remember that we have some interesting data with adjuvant nivolumab. And so from that perspective, depending on what the FDA does with that, I didn't touch it, you may be able to give split dose for those patients with a creatinine clearance down to 40. If you want to talk to either of us about that, we'd be happy. And then afterwards, if there's a suboptimal response with bulky stuff left, then give a year of adjuvant Nevo if that's approved. And I think it's time for us to wrap up.
Yeah, thank you. It looks like everyone's going to have a quick break now. And there is still time to earn points toward the Engage and Win giveaway by chatting with industry representatives in the exhibitor hall. So you can go to their booths and pick up some information and interact with them there. But thank you for tuning in, and thank you, Dr. Quinn, for an excellent Q&A session.
Thank you very much, Dr. Dorff, and thanks everyone for making time on a Sunday. Hopefully it's been good.